issues that we are likely to encounter in histopathologies. But the way I'll be doing it, I'll rather address what is expected of you as a client that is bringing samples to us in the lab. So from there, I will talk about the issues that could arise. I hope everyone can hear me clearly. Oh, all right.
Yes, sir, we can hear you. Please go ahead.
Okay. We can hear you.
All right, thank you. As a form of introduction, I don't know why this is hanging. Okay. As a form of introduction, we are SynLab. I love telling people about SynLab, the laboratory with a special ability to deliver quality standards and quality reports anytime, anywhere, any day. And is the #1 European medical diagnostic provider in Nigeria. And we have a lot of strength in SynLab. We are present in over 40 countries in almost 5 continents now in the world. And we have more than 20,000 employees. And per year, we do over 500 million different kinds of tests, and more than 1,000 medical experts are in SynLab Group, which is what we stand for. We stand for quality, and we stand for high standard of tests. So we can say we are stronger together. We are everywhere in Nigeria, both the south, the north, the east, and the west. And so it is easier for you to reach us. And we do different kinds of analysis, which include coagulation, chemistry, hematology, microbiology. And today we're focusing on the pre-analytical issues in anatomic pathology. So ANAPAT, as a form of introduction, is anatomic pathology and is the diagnosis of diseases through the examination of organ or tissue specimen by the use of microscope or through molecular, biochemical, or immunological means. ANAPAT deals with tissue preservation, tissue examination processes, morphology, with other analysis of tissue that is removed from the body in order to make an accurate diagnosis that is needed for decision on patient treatment option. So when we talk about anatomic pathologies, there are quite a number of things it comprises, which include histopathology as a major part. Then there is a new one that we've introduced into Nigerian market called digital pathology. That's converting our slide picture, that's the photomicrograph, to a digital form. So that photomicrograph can be used for so many things, including training, including tumor board in some institution. So if there is any institution that is dealing with us and they want to also discuss, the morphological changes that we saw to come into a particular conclusion of diagnosis, it's so easy for us because we also have a scanner and we can do that. We can, special stain is a part of it. Immunohistochemistry is also a major part, and we do that also regularly. We're hoping we'll be able to domesticate it in our Nigerian lab as soon as possible. And of course, cytology. Okay, so pre-analytical issue. Let me start by saying the most important pre-analytical issue in histopath include 3 basic things. #1, preservation of specimen integrity. Everything we do in histopathology lab is to process a tissue. And there's this common saying, garbage in, garbage out. So if I get a bad tissue, I will process a bad tissue and I will get a bad slide. But if I get a good tissue, I'll process a good tissue and I'll get a good slide. The integrity of the tissue submitted to me will determine the quality of the result I will give to you. Number two important issues in another part is proper identification of specimen. So it's a lot of challenge, and I'll be speaking to that in a jiffy, whereby we get specimen that are not properly labeled, just one name, no age, no sex, no nature of specimen, and all the other important specific identification for that patient. This third one is correct logging of specimen for proper billing. We have a lot of issues with logging. So some may come with a very big sample, and yet they want it to be logged in our banding system, band 1, and pay a token. It doesn't work like that because a lot of reagents, a lot of things goes into production of a slide. Talk less of a case that we might need to get like 10, 20 slides in order to make a good diagnosis. So let me pick them one after the other. The first one is sample preservation. So I will take histology, I'll take for slide, and I'll also take for cytology and second opinion. All right, so for histology, all biopsy or resected specimen must be put in a preservative immediately after the removal from the body cell. So if I'm talking to surgeon or oncologists, there's a problem we usually have. And I've made several efforts before to speak to, our clients, the doctors, the oncologists, the surgeon, especially to talk to their assistants, to talk to their nurses that are with them in theater. Because once a tissue blood supply is cut off during resection, during removal of that tissue from the body, immediately ischemic time begins because that tissue starts decaying. That's the truth. So if that tissue is not preserved, immediately it's being removed from the body, then before it gets to a preservative fluid or before it gets to the lab, a good quantity of the cells we are looking for will have been, either damaged or autolyzed or destroyed. So it makes, diagnosis very difficult for us to make. So it is a very important aspect. Anytime a tissue is removed from the body, before that tissue is cut completely from that body, at least a container should be available that will take the sample, number one. Number two, that container should be properly labeled. Number three, there should be preservatives in it. I'll talk about the preservative in the next bullet. So those three things must be, done before the tissue is removed from the body. So we have so many occasions whereby they will remove the body and put it on a gauze in the theater for hours until they finish the surgery. Then they will now be looking for container and be looking for formalin, which is the preservative. And that time that was spent, a lot of cells might have been destroyed because they are not preserved. So immediate preservation is very important. We have a lot of cases like this that you have the tissue, brought, processed, did everything. And while we're looking at it under the microscope, we realize that quite a number of the tissue has been autolyzed. So it will be very difficult for you to see the morphological changes within the cell that will give us the opportunity to make an accurate diagnosis. Number two is the standard solution commonly used for preservation. The standard solution we use is formalin, and it's not just formalin. It is a 10% neutral buffered formalin. All this the formalin stock comes prepare a 10%. If you use the stock, it will shrink the whole tissue. We won't even see anything. And if that tissue, if that formalin usually slightly acidic, is without neutralizing it, there will be this blood reaction with the acidic component of the formalin to form a brown, and that pigment will definitely cover the whole tissue we're trying to evaluate, and it makes it so difficult to see the morphological changes that we need to diagnose. So it has to be a 10% neutral body for any of our clients that are required to realize their scientists how to prepare needs be. So the appropriate sample container. So you can see a whole large sample, and they will force it in small container. Occupy the container. A small can never be fixed and is deteriorating already. So the third one is talking about this formalin volume. The volume of formalin must be appropriate. When I say appropriate, it means at least the volume must cover the tissue in the good container. The problem of forcing a tissue into a container when after surgery is that that tissue was soft. It can go into the container, but by the time it fixes a bit, then it's hard for us to get it out. Sometimes we have to break the bottles, cut the containers for us to bring out a tissue that was forced into a particular container after surgery. So number one, the content must be adequate. Number two, the formalin must be appropriate. So the volume at least cover top of the tissue, and that will ensure proper fixation. Now for slides, because some of our clients, they do FNC, they do aspirates in their side lab or their clinic, and they pay. Sometimes they will send us slide to us after 2 days without fixing. And this is surgery. They are cells. After like 2-3 hours, if they are not fixed, they degenerate. So when they send it to us, we fix it in the lab and try to stain. And looking at it under the microscope, you're seeing any cell. You just tell them it's hypoplastic. And when they took the sample, it was quite cellular, but all those cells are degenerated before they got to the lab. Why? Because they did not fix it. So every slide for studies must be labeled properly. We also have a situation whereby they just take slide A, B, C, D, and that was all they wrote on, and they send it to the lab. That was not the proper labeling. So it has to contain a name and at least the age, the sex, and probably a number, a unique number for proper identification of the slide. That takes 95% alcohol, at least 15 to 20 minutes before you can now, if you don't want to send it with the liquid, when it's fixed for 15 to 20 minutes, you can take it out, air dry it, then package it properly in a good container, and then send to us in the lab. So air dry slide should be packaged properly and sent to the lab. Okay. Okay. So for liquid-based cytology, you can see the container on the upper right. So this for cervical smear, we use brush. So please take an appropriate sample will be taken with the brush. The nurse that trained can take it. That's good. But this sample bottle has space for proper labeling. And this is the name, the age. I'll tell you the unique identifier as I move on in this presentation. The age, the name, the sex, must be there. Then when the brush is used to collect the sample, is broken, that white part, the white head of the brush is broken into this container. And the container usually comes with a preservative fluid inside it, which is about 8 mils. And once that thing is broken into it, it has to be properly, sealed and properly corked and sealed and sent to the lab. We have occasion whereby the preservative fluid leaks away in the process. I will tell you how to properly seal container later in this presentation. So that's another issue. It has to be properly locked and then sealed before sending to the lab. For non-gynae cytology, when I say non-gynae cytology, let me just show you the next slide. So this non-gynae cytology includes, exfoliative cytology like urine, CSF, sputum, and effusion from the body, which could be from the pleural space, from the pericardial or peritoneal cavity. Abrasive cytology like imprints, like what's it called? Endoscopic brushing, bronchial lavage, all these fall under non-gynae cytology. Fine needle aspiration for cytology, also for all palpable tumors in the body, are also examples of non-gynae cytology. All of these we can use LBC procedures to also do them. But if they are just tiny tissue, you can take it and flush it inside this preservative fluid, lock it very well, and send it to us. But if you have a large volume, some volume that is less than 5, just add equal volume of preservative to the sample. That's the preservative in the BD sample collection. Seal it properly and send it to us. There is no problem. But we have issues when you have above 5 mils. So if you have above 5 mils, we appreciate if there is a side lab in the clinic or in the hospital or in the side lab in the hospital. So that particular volume should be poured in your normal centrifuge tube and spin it, maybe 600 RPM for 5 minutes. Definitely all the cells in the sample will have sedimented. And so let it be decanted. And when it gets to like 3 to 5 mils, you can resuspend all the sediments and pour everything back in our container. And that can be sent to the lab. We realize that so many non-gynae cases are not fixed when they get to the lab. So this becomes a very important information that I need to pass across, because it's a big issue. We have a system that can concentrate the cells, no matter how small they are. Unfortunately, the cells are concentrated, and unfortunately, they were out there because they were not preserved at all. So with this preservative fluid, anything you are sending to us, if it's non-gynae, once it's below 5 mils, it can be poured into the container, sealed properly, and sent to us. If it's above 5 mils, spin it down, decant as many volume as possible. Once you have like 3 to 5 mil, resuspend the pellets and pour it into the container and send it to us. It will be properly fixed, and then we'll be able to use it. So if you cannot see your lab, there is no centrifuge, then no matter how big the volume of the sample, please help us get an addition, a 95% alcohol, and add equal volume of that 95% alcohol to the sample and send it to us. It will be fixed. All right, so for transportation, which is also a very important aspect, because we receive a lot of samples that all the formalin inside has poured away during transportation. We've received broken slides before, and all these are not very good because they are usually part of our exclusion criteria, which I will talk about briefly. If you look at to my right side, you can see this whitish materials. We call it paraffin. paraffin. So after putting the sample after putting the sample in the bottle and properly corked or locked, then if you can always get this paraffin and use it to wax the mouth of the container from the lid to the body, and that will securely, keep the lid from opening, and no matter the condition when it's being transported to the lab. And for the slide also, there are slide packer that we can get that, you can carefully arrange the slide into it. Each of these can contain like 5 different slides, and this will prevent, breakage and the like. Oh. So for second opinion slide or second opinion cases, we have issues with second opinion because you said it's second opinion. One of the things we need is the first opinion. It's not because we are looking for expo, or what do they call it in secondary school now? Some people will say, no, I'm hiding the first opinion. Give me your own opinion. The danger in that is that I give you my opinion based on the morphology. So if the first opinion you have is saying this thing is fibroadenoma, and my own opinion is saying it's fibrocystic change, now you have 2 different opinions. Which one will you go for? Now, that's the reason why we ask for the first opinion is that if you give us a tissue for second opinion and you give us the first opinion, the first thing we will do in the lab is first of all to rule in or out the first opinion. So if the first opinion was correct, then it is correct. That's one. The second thing we do is to now look further if there are other things that we can add to the first opinion, reviewing it again the second time. Now, if we have gone beyond that, now in a situation whereby we disagree with the first opinion because you have given us the first opinion, we can even decide to do a conference discussion on that issue. I can share it with a lot of my senior colleagues in Europe, and we look at the tissue together. Oh, this is a second opinion. This is what they call it for. This is what I think. And all of them submit their opinion. I will have gotten you the second, the third, the fourth, the fifth opinion on that same slide, and the report I'm giving you will be a conclusive diagnosis that you don't need to bother about looking for any other opinion again. But if you don't give me the first opinion, I will only submit my opinion, which is another opinion, which may be in line with the first opinion or may be contrary to the first opinion. And then you will now you'll be left with to now get a third opinion to know which either the first or the second is correct. So we prefer them giving us the first opinion so that it can help us to help them to make a conclusion on the case. So that's why some ask, in fact, not sometimes, most time we ask for the report of the initial, histology that was done. Then we also need a properly labeled tissue that is positive. Sometimes they will give us a tissue block that is not representative of the first diagnosis that was made. And that's in its own is not good because we will give opinion based on what we see and not what they thought. We can't read their mind, so they have to give us the tissue block that they use to make the diagnosis, a positive tissue block where what they are thinking is present in that tissue block. That's the only way we can help them to conclude on that case. Also ensure that the tissue block is covered with wax. So if they want to retrieve a tissue block, we like this, whosoever is making the request, to tell whosoever is going to the previous lab, to tell them to cover the tissue with wax. It's just to put it in the hot embedding machine where the is and bring it out. Because if it's not, that tissue will be exposed to air. Sometimes it will be dry, sometimes it will be very hard, and it will be very difficult to cut, in fact, breaking away during processing. And also a properly filled requisition form will be needed. We realized that tissue block will just come from the hospital, from the surgeon, saying they say I should give you for second opinion. No form, nothing. And the patient might even know what the doctor wants. So we need a properly filled requisition form from the doctor stating the type of specimen, stating the detailed clinical information, probably adding to us their own clinical in the form. It will really help us a lot. And also in the form, we also need the physician name and the contact details. Sometimes we want to discuss with the physician, because what we are saying, we need to correlate it with clinical information, and we don't have enough clinical information. Sometimes it takes us 4 days to get the clinical information. And sometimes there are some cases I can't sign out until I get a clinical information. We call it clinical pathological correlation. So it's very important. But if those things are not, it can constitute the reason for delay, release of tests and prolonged TAT. Proper identification is very important. So let me just run through this slide. I should be running off in some few minutes. The details on the request form should include, but not limited to, the following. Number 1, patient identification. It must include at least the full name, the gender, the age or date of birth, the phone number, and the email of the. If you don't give us email, the result is ready. You have to come and pick the result before you can get the result. But if you drop your email, we can send it to you by mail. The contact details of the patient is optional, but those first things must be there. Name, the phone number, the gender, the date. We don't see a lot. There was a time where, in fact, it was so terrible that you just see a name, histology, just one name, not even 2 names, not even 3 names, one name, then the next thing, tissue for histology. It doesn't make sense. On a good day, I'll reject such. We need to give proper information, because it will help the people that wants to look at it to be able to make a lot of decisions. There's a tumor they call blastoma. If I see a medulloblastoma, that's the tumor.
Hello, Dr. Adeton. I think we lost you. Hello. Hello, Dr. Adeton. I think we lost you. But before he joins back, please try and follow us on our social media platforms. We're on Twitter, LinkedIn, Facebook, and on Instagram. Our address is known as LabNJ. And then please, for your questions, you can use the chat box.
Can you hear me?
Questions will also be taken. Yes, we can hear you.
Oh, okay, great.
Questions will be taken right after the second sessions. You can write down your questions, put it in the chat box. You can as well hold on and ask your questions after the second session. Please continue, Dr. Adeton, and you have a few minutes to round up. Thank you.
Right. Thank you. So that same tumor, if I see it in the same tumor, but the location, the site of the tissue determines the name. So and if you don't give me the nature of specimen, I don't know. I will see the tumor, I don't know. There are some tumor, if I look at them, they are malignant, they are cancer. It can only be found in children. If you don't give me the age, I get stuck. Because if it's found in adult, it's a rare case. It has to be reported. So, and you didn't give me the age of the patient. So every unique identification is more than just to identify the tissue and the form. It's even gone beyond that to an extent of it affects even the decision on what the diagnosis is. So let me just move on. So the clinician, his name and their phone number is very important. We don't need to all that if we have all those things ready in the form. Specimen type, very important. Anatomic site, where the specimen is taken from, important. Sometimes I don't touch tissue if I don't know where they came from. I would rather
Hello, Dr. Adetulo, we can't hear you. Sorry, it seems we've lost Dr. Adetulo. Again, like I said, please follow us on our social media platforms. We're on Twitter, LinkedIn, Instagram, and on Facebook. Just search Synlab Nigeria and please follow, share, and subscribe to our page on YouTube. Please, this session is also recorded and it will be on our YouTube platform. In case there are some of your friends who are not able to join this session live, please try as much as possible as you can to inform them to go to our YouTube page and gain and enjoy this webinar. Hello, Dr. Adetulo. Sorry, we lost you.
I'm so sorry. I don't know what's going on here. Yeah. All right, let me just quickly wrap up. Okay. So very important. Examination requested. You should, if it's histology, please put histology. If it's was for histology, the other one was for microbiological tests. And they sent the two to us, and it was logged under histology. And we have to add formalin to a tissue that's supposed to go like that to, microbiology. So the type of examination must be indicated. Then we also need clinical relevance information. Maybe there's a radiological study, endoscopic diagnosis, previous surgery done, different diagnosis, differential diagnosis. All this must be supplied to us. It always helps us to make an accurate diagnosis. Let me just run through acceptance and rejection criteria from us, even though not absolute, but these are things that everyone should take notes of when you are sending samples for histopathological services. Histology request form must have at least 4 key identifiers, which will include the names, the gender, the age, and the specimen type. Also, specimen container must be labeled clearly and unequivocally with a minimum of 3 key patient identifier. So you label the form, you label the container, because the container must also carry. In fact, we've seen a situation whereby 2 samples came in and they have the same name, Abdullah Mohammed. And it's other things that we use to now differentiate between the two. So full name, specimen type, the age, the gender, and the specimen, the dates the specimen was collected. Rejection criteria is an issue, it's a major issue. At least we must have the 4 unique identifier. Most of the time, you don't have the 4, you only have 1. On the container, on the form, patient data on the form and the sample container must match. Sometimes you have these, they will put Adejoke Abdullah and they put Adejoke Maureen in the other one. Is it Abdullah that is Maureen? And it's the same patient. Every other thing is the same, but the name, 2 different names. Because he has 3 names, they decide to put 2 on this and 2 on the form. It's so confusing. Specimen submitted without appropriate requisition form, improper specimen fixation. You will see, in fact, we've received from hospital, decayed specimen, not once, not twice, not 3 times. Recently, we still received one. We opened maggots everywhere. and they wanted us to process it. How? So it's with very difficult. Improper fixation of specimen, broken slides or broken container. These are terrible issues. All specimen must be accompanied by a completed requisition form appropriate to the specimen. Failure to complete the form will lead to delay in the processing of the tissue and invariably leads to extension of the TAT. I don't know if
Dr. Adetono, please have 2 minutes to round up.
Okay, thanks.
Sorry, but we have 2 minutes to round up. Thank you.
Correct logging of the specimen for proper billing is an issue. We have this form. I don't know if every of our clients has this form also. You know that it's a banding, that's the system we use, banding system, band 1, band 2, band 3, band 4. Before you even call us, if you have this form, just look through, you will see. The banding system is based on the complexity of the tissue and the size. Tiny tissue, band 1, a little moderate tissue, band 2 or band 3, big tissue, band 4. So, and it's L. So, as a form of conclusion, SynLab Nigeria and our parts, we are known for quality, and we have an advantage in SynLab and our part, which include the following because of the time: short CAT, better price. We have a special ANAPAD request form, like I showed. We have, a good quality report from a trained pathologist. We also have direct access to pathologists for specific cases, discussion and consultation, which we do regularly. And second opinion is very easy with us. We have a whole group of pathologists in ANAPAD, SynLab Nigeria, that we communicate to every day, and we can get second opinion, third opinion, any opinions that we want. And you can also access your reports through our part provider, so you don't need to come back for that. This is a cross-section of our lab for histology and also a cross-section of our lab for liquid-based cytology. We have hotline to other parts, which you can call us directly to the lab, and that's the one displayed there. Thank you very much.
Well, thank you very much, Dr. Adetono. That's quite a huge one and well detailed. I'm sure so many people must have gained one or two from this presentation. And now moving on to the second presenter, a brief information about the second presenter. So the second presenter we'll be having today is Dr. Afolabi Obe. He is an alumnus of the Ladoke Akintola University of Technology, an award-winning fellow of the National Postgraduate Medical College of Nigeria. He is results-oriented with expertise in management of medical diagnostic laboratory. He, amongst many other things, he is part of the team involved in the management of Ebola virus disease outbreak in 2014. He also coordinated the COVID-19 project of SynLab Nigeria during the COVID-19 pandemic. Dr. Afolabi Obe is an executive member of several bodies in Nigeria, which includes College of Nigerian Pathologists, a member of Society for Quality Health Care in Nigeria. He is also a member of Infection Control African Network, a member of European Society of Clinical Microbiologists, and also a member of Biological Safety Association of Nigeria. He is motivated by providing quality pathology services, which help to improve the health outcome of Nigerians. Currently, he is the Chief Medical Officer of SynLab Nigeria, saddled with the responsibility of leading the medical strategy, supporting and coordinating a sustainable and responsive diagnostic network with the aim of achieving the company mission. He's not just a loving husband and father, but he's also a lover of fun and a big believer of a new Nigeria. Join us in welcoming Dr. Obe for his own presentation on pre-analytical issues in clinical laboratory, the microbiology perspective. Dr. Afolabi Obe, you're welcome. Please take us through your presentation. Dr. Byfield, you are muted, but before you join us again, please, we're on several social media platforms. We're on LinkedIn, Twitter, Facebook, and on Instagram. Search us with the name Synlab Nigeria. Please join us and like our page. Encourage your friends to also join. Once again, this webinar is being recorded and is on our YouTube platform with the name Synlab NG. Please join us, subscribe, and also share to your friends. Again, questions will be taken after the second session, but if you feel you forget your question before the end of the second session, please, you can also use the chat box to note it down. Thank you. Dr. Ube, you have the floor.
Right. Thank you very much, Izine, for the introduction. And thank you, everyone, for finding time to join this conversation this afternoon. I'm going to be taking us through the pre-analytical issues in clinical laboratory, focusing on the microbiology perspective within the next 20-25 minutes. Right. I want to start my conversation with a case scenario. Mrs. A.N., it's a 36-year-old whose urine sample was presented for urine culture alone, no urinalysis. No clinical details was given, no recent or current history of antibiotic use, and the outcome of the urine culture yielded a mixed growth of Escherichia coli and Enterococcus. This is a typical scenario of what we see very frequently in the laboratory. And this is one of the pillars that depicts, our focus, the pre-analytical issues affecting results. So what are the concerns here? Two pathogens are isolated. Me and you will agree that only one of them is the cause of the urinary tract infection. Which one of them, we don't know. No urinalysis to troubleshoot and pick on one. So what are the issues here? It means that the patient cannot be helped. No value for money. The patient will have a distrust in the lab, will have a distrust in the clinicians who sent her to the laboratory. Work done, zero. And so let's go through what will be causing this. What is our objective this morning? Sorry, this afternoon, is to understand the importance of pre-analytical processes in medical microbiology. To also be able to identify common challenges and errors in pre-analytical processes, and then to learn the strategies that we can use to optimize pre-analytical processes to enhance accuracy and efficiency. It's important for us to also know, as a way of introduction, that pre-analytical processes refers to the steps that are taken before actual analysis of the sample in medical microbiology laboratory. And these include patient selection, appropriate tests, sample collection, sample transportation, and sample storage. And research has shown that close to 2/3 of laboratory errors are pre-analytical, meaning that if we're able to handle the pre-analytical issues in medical microbiology, vis-a-vis clinical laboratory would have reduced error rates by over 60%. So ensuring proper pre-analytical processes is therefore crucial for accurate and reliable results. A glimpse into the situation. Averagely, as a consultant microbiologist, I receive about 7 calls per week on cases of samples presented at any of a laboratory with no request indicated on the form. Dr. Adetona has also mentioned scenarios like this. You bring a tissue to the lab, the patient's name and sex and age may be there, but nobody tells you what tests they want to perform. Whether it is histology, whether it is cytology, Whether it is microscopic culture and sensitivity, nobody knows. And then this is where error began. 3 out of every 10 blood culture results comes out as mixed growth. This is huge. For bloodstream infection, more likely than none, only one organism is causing this infection. And then by the time you have 2, you won't know which of them is the pathogen. I mean, the whole business we do in microbiology laboratory is to be able to isolate a particular organism, run the susceptibility testing, and then the clinicians will know what antibiotics to give to help the patient. But mind you, organisms are everywhere. Normal floras are everywhere, on the skin and everywhere. So whether the one you are picking is the true pathogen causing the infection or not, you don't know. And it's a major problem. And this can be prevented if due diligence are done during the process of collection. Again, about 32% of urine sent for MCS also results as mixed growth, like the scenario I have painted. These are huge problems. And these are really huge problems. So what are the common pre-analytical issues? We're going to be taking few time here. Sample collection, wrong sample type. Somebody filled sepsis in the request form, and you are sending urine sample. You didn't say UTI. You didn't say overwhelming sepsis. Confusion starts from there. Wrong bottle type. You take a bottle that is supposed to be meant for liquid-based cytology, you are putting urine sample, or you are putting tissue, you are not putting formalin. There is confusion there. And so it is important that we know the right thing to do. Poor client preparation or poor patient preparation, especially, I want to talk in respect of 2 major samples that we received: blood culture, urine MCS. There are standard procedure for sample collection for urine. Patient is expected, if it's a woman, to part the vulva, to wash the vulva with water, part the vulva, especially the labia majora and labia minora, then start to urinate, and you pick this urine sample in the middle of urinating. This is the ideal sample. Why do we need to do this? The vagina is filled with organism, and when urine is coming out, if the vulva is not well parted, the urine coming from the bladder where the organism is, we wash all the contents of the vulva. We wash it into the container. And then on the vulva, you have normal flora. Staph aureus is there. Streptococcus agalactiae is there. Some people who don't have very proper hygiene, Escherichia coli may be there. So it's difficult, really, to know which of these organisms may be causing the cystitis. For blood culture sample, there are standard guidelines for preparation for sample collection for blood culture. And it is important that we follow this. Wrong timing of collection, especially blood culture. There are standard period for collection. Number 1, for patients on admission, you want to collect sample for blood culture at the peak of temperature. This is when you expect a bacteria, the fever means that the bacteria are growing well and they are present in the blood at that time. Or you take the sample at the trough of antibiotics, meaning if the person is taking antibiotics morning and night, just before the night dose or just before the morning dose is the right time. Why? Because the serum level of the antibiotics would have gone down at that time. And this is very important for blood culture. Apart from this, it is also important that request forms are filled properly. How do I mean filling properly? The name, the age, the sex, clinical details, current antibiotics the patient is on, the sample type, the collection time, the physician name, the physician contact if it's possible. Perhaps we want to reach out to the client. It's important we have this one. Sample transportation and storage. There are times that there will be delay in sample getting to the lab. There are standard guidelines to follow. For example, cerebrospinal fluid. You don't want to refrigerate. Keep it on the bench. Don't put sample for CSF in cold chain coming to central lab. It is not appropriate. Why? Because two of the common organisms you are interested in, Haemophilus influenzae and Neisseria gonorrhoeae, Neisseria meningitidis, that cold environment can inactivate them, and it will be difficult to recover them. Don't refrigerate sample for blood culture. Leave it on the bench there till the time you are moving it. As small as these things are, they are very important in guaranteeing the quality of results that you bring out. So what are the impacts of pre-analytical issues? There are impacts to the clients, there are impacts to the clinicians, and of course, there are impacts to the lab. To the clients, there is delay in treatment. For example, Mrs. AM, he has UTI, obviously, sent urine, mixed growth. Doctors can't treat. You don't even have the antibiotics to treat. So delay in treatment. There will be increased cost because she has to present again for the same test. Then the patient may have distrust. Why is it that they cannot do ordinary urine MCS, not knowing that the problem comes from her and the people that she saw first? These are the impact of pre-analytical issues. So the clinicians, it leads to misdiagnosis. If you identify the wrong organism because contaminant was picked, you run sensitivity testing on contaminants, especially from blood culture. You place the patient on antibiotics. Patient is not getting better. The lab has misdiagnosed, as misinformed the clinician. This could also lead to distrust. And to the lab, increased workload, wastage, and again, distrust. These are impacts of pre-analytical issues, to the results that we have. So what are the strategies that we have for optimizing pre-analytical issues? Number one, we need to implement standard pre-analytical processes for collection, sample transportation, and sample storage. This is available with us in SynLab. I mean, if the partner hospitals, you are on the call, this is the reason we're doing this education. If you have support in this regard, we're willing to offer support. Right. It is not only enough to have these pre-analytical processes documented. It is also important that people are aware of them. So there is a need for training. And of course, a periodic retraining to every laboratory personnel so that they are informed of all those processes. And of course, to put quality measures in place to also ensure that people only do not know, but people practice what they know. So, and again, people should ensure that we foster a culture of continuous improvement. We should do a periodic auditing, find out where our gaps are, and then try to improve on our gaps to make the system better. Ultimately, the output of what comes from the lab, is getting better, and the client or patient or clinician is getting satisfied, and everybody is happy. So these are the strategies that we can use to optimize pre-analytical errors in clinical laboratories. So what are the benefits of optimizing pre-analytical issues? Number one, there is improved accuracy and reliability of the results. If we do all the things that I have mentioned, following SOP, training and retraining, put up all quality measures, ensures that people follow them, have a culture of continuous improvement, all these things done together will improve the accuracy and reliability of results. And people are happy. It reduces the need for repeat testing. And of course, this leads to client satisfaction. It enhances patient safety and satisfaction. It reduces the cost of health care. It reduces hospital stay. It reduces the risk of antibiotic resistance. And of course, there is fast turnaround time to patient care. In all of this conversation, what advantage is SynLab bringing on board to help to achieve this? Number one, we have a robust laboratory information management system that details all pre-analytical concern, meaning that if you're concerned in your hospital, in your small lab, partnering with us, even parts of SynLab that you're in other locations, BCPs, our LIS is a compendium that you can get any pre-analytical issues of concern there. And so we should make use of this. The customer care, it's 24 hours all around the clock. If you're concerned about anything, pre-analytical issues, either you're within SynLab or outside SynLab, a customer care, it's a call away. Maximize this to ensure that we improve on the quality of a result. Again, we have discipline-specific pathologists who are always available for a call. Consultant histopathologists have spoken with us just about 25 minutes ago. Microbiologists are speaking with us. We have chemical pathologists. We have consultant hematologists. The essence of having these people within the organization is that they can be a huge resource to us to help resolve some of these issues. And it is important that we use them either within clients or clients that are outside if they're on the call. And again, in SynLab, we have established quality management system. Why is this important? This is important because when there are errors, the system is able to pick the error on time. Number one, the system is able to prevent us from making errors. Perhaps it does happen. The system is able to pick the error on time, and then the system is able to put up preventive measures such that this error do not occur again. These are the advantages that SynLab is bringing on board, and I want to appeal to us as staff at outstations, partners hospitals, partners laboratory on call with us. Take advantage of the SynLab advantage to ensure that our output becomes better and our clients are getting satisfied with the results. In summary, optimizing pre-analytical consent is crucial for enhancing accuracy and efficiency in laboratory testing. Implementing standardized protocols, utilizing automation, focusing on quality assurance and control measures within the healthcare institution can achieve improved patient outcome, and invariably it will save costs. Thank you everyone for listening. I think it's a convenient time to hang. Thank you.
All right, thank you very much, Dr. B. It was quite a huge one. At least I was able to pick up one or two things. Please, if you have questions, you can signify by raising up your hand or dropping it on the chat box. And then There will be a poll that will be coming up immediately after the session ends. Please help us to fill up the poll as to help in picking up ideas to organizing a better webinar. And then before you leave, please remember to follow us on all our social media platforms on LinkedIn, on Instagram, on Twitter, and on Facebook. Search for SynLab NG and follow us. Again, this webinar is recorded and it's still live on YouTube. For your friends, colleagues, family that do not have the opportunity to join the live webinar, they can as well go to YouTube and have a rewatch. So please, time for your questions. So before the question come up, I have some questions. So the first goes to Dr. Adetosoji Adetola. So my question is, aside from formalin, the neutral buffered formalin, are there other fixatives that we can use? And then, does the fixation also affect immunohistochemistry? And then can we use the same sample used for histology for immunohistochemistry? And then my second question goes to Dr. Afolabi Ube, the second presenter. I heard you mention how the female's gender is supposed to collect the sample for urine culture. Well, I didn't hear you talk about the male. I was thinking you are going to talk about the male, at least to balance the gender stuff. And then for the urine also, are there specific time for collection, or can the urine be collected at any time for urine MCS? Thank you very much.
Okay, thank you for the question. If I can respond now. Yeah, there are other fixatives that can be used. There are so many fixatives. In fact, there are 5 different groups of fixative. But the commonly used one is 10% neutral buffered formalin. But because 10% neutral buffered formalin can fix any tissue appropriately well without any significant, damage or modification to the morphology of the cell during processing. So there are other, like if you are dealing with tissue like testes, there is a particular Boeing solution that can be used, that is specific for that. If you are looking at a sample that you are planning to do electron microscopy, glutaraldehyde is a better fixative. So we have all sorts of fixatives like that, but the most commonly used, commonly accepted, easily available, and with little or no, significant adverse effect on the tissue itself after fixing it, is the neutral buffer 10% formalin. So yes, the tissue that is formalin fixed can be used for immunohistochemistry, as you asked, yes. But the fixation for immunohistochemistry has a specifically slightly different, careful adjustment in the sense that if you know that this tissue is likely to go for immunohistochemistry, it can be fixed. It should not be fixed longer than 48 hours. The reason why I won't dwell so much on that is that for SynLab, if your tissue gets to our lab within 48 hours, we process it. So, but if it's a lab that they have an habit of keeping sample or pulling samples for a long time to get to a particular number before processing, then that will be a major issue. Because if you fix a tissue that is going for immunohistochemistry for more than 48 hours, the cross-linking of the protein bonds will be so much that for them to be able to retrieve the antigen that will be stained for the immuno will be very difficult. And majority of those cases will come out as negative immuno, whereas it is not because the antigens are not there, but the fixation was too prolonged. Then there was a third question that I can't remember. I think.
No, the third question is for Dr. Obi.
Okay, thank you.
Thank you very much.
Right. Thank you, Ezine, for the question. And permits me, I'm not gender biased, but then I think it's because male generally, we don't have high prevalence of mixed growth from urine from them, not because it doesn't happen. So for a male, what do we expect you to do? Clean your papers, that's the glands, clean the glands penis, and then collect the sample into the container at the middle of the urination. That would just be fine, because the initial voided urine would have cleared all the things that it meant to clear. As again, for women, there is a continuous passage of the urine through the vulva, hence the need to pass the vulva. So regarding the specific timing for collection, you can collect urine sample at any time, really. It's just that the yield increases with early morning urine sample. But with the way we operate in our environment, except you give the container to the person to take home, that when you sleep and you wake up, the first thing you want to do is you want to collect this urine. The one they collect at 8 or 9 or 10 a.m. in the morning is not early morning again. Essence of early morning is because the urine would have accumulated in the bladder for about 4 to 6 hours when the person is sleeping. The few bacteria that is there, you would have given them enough time to grow. You will agree with me that the doubling time for most bacteria, especially Enterobacteriaceae, say between 15 and 20 minutes. So with 3 bacterial cells in 6 hours, you're probably having, multiplication of like 200. Then the ability to recover that from, the culture media in the lab is high. But then with very good quality materials and the sort of quality measures we put on agars, with 1 or 2 isolates, yes, you are able to recover whatever organism you have in the urine, even if the sample is collected at any time. I think that would just be an appropriate answer to your question. I don't know if I have any other question. There is none on the chat box. Thank you.
All right. Thank you very much, Dr. Ubi, for the clarification. Thank you very much to Dr. Aditono. It was quite impactful. So please still follow us on our social media platform on Instagram, Facebook, LinkedIn, and on Twitter. Again, this webinar is recorded and will be on our YouTube page. Search Syllab NG, follow us, share, subscribe, and put the notification on so that you always know when we are live. Please, the poll will still be coming up just immediately after this webinar. Please help us fill it in, as it will really help us in gathering information to better organize the next webinar. Thank you very much for joining our session today. We do appreciate it. Please enjoy the rest of your day. Thank you.
Thank you, Ezine. Thank you, everyone.
Thank you for presentation.
Thank you, everyone.
Thank you.
So the poll is on now. Please fill it out. Thank you. After you leave. Oh, sorry, before you leave.
Nobody asked. All right. Thank you very much.